No, now we're recording. All right, Josh.
Okay. All right, everybody. Thank you for being here today. We're going to go ahead and call this meeting to order. Perfect. Good job. For those of you who don't know, this is my son who's with us today to observe. He's actually going to summer camp. So thanks, Evan. Appreciate it. How you doing?
Nice camel work.
Yes. Welcome.
Kevin.
Perfect. Let's go ahead and Shelley, we'll do roll call.
All right, Allison Milt.
Present.
Ariel Moreno. Barb Stoltzfus. Candace Williams.
Present.
Carrie Lewis. Corey Usher. Dale Woolridge.
Here.
Deb Burkick.
Present.
Garth Gamer.
Present.
Heather Miller.
Present.
Josh Gaither.
Here.
Julie Augenstein.
Present.
Laura Smith.
Present.
Maria Salas. Here. Michelle Guadagnola.
She's offline, I see.
Might need to hit *6 to unmute a telephone. Michelle, if you could chime in, we need an audio for you. Audio check for you.
You can put something in the chat as well if you're having microphone issues. That will work as well.
Paul Dabrowski. Ralph Kelly. Ray Proa.
Ralph really checked in online
Present.
under Rochelle Eddy.
Ralph, Dane, if we can do an audio check with you as well, please. Shanna Club.
Yeah, it's Dane Kelly here
Present.
in Cuba City.
Oh, perfect. Thank you. Shanna Club, I got you.
Okay,
online.
yes, I'm here, present, thanks.
All right, thank you. Sean Bowker. Stevie Merrill.
Present.
Tiffany Streever. Tom Flanagan.
Present.
Count 17, we have quorum.
Thank you very much. All right, we're going to start with the chairman's report. Please take a moment to eye your attendance reports. For those here, you don't need the reminder, but please do recall that if you've missed more than 2 consecutive meetings, the DHS will reach out to you to see if you're still interested in continuing in your position. Thank you all for being here today. We really do appreciate your support. Moving on, we do have a couple vacancies. We have one in Southern Arizona. If you're a pre-hospital EMS coordinator, please send an email to Sarah Parati and myself if you're interested in filling that role, and we'll get someone there. Similarly, we have a role for law enforcement representative. That law enforcement representative must have an active involvement in EMS. If you know anyone who may be interested, willing to do that, and have the relevant expertise, please encourage them to submit a resume or CV and letter of interest to Shelley. Correct? All right. Last thing on my report, we do have a meeting schedule. You can click the hyperlink. Please check that out. Put those dates on your calendar. We look forward to seeing all of you in 2025. With that, I will turn it over to Chief Garcia for the Bureau report.
Thank you very much. Good morning to all of our TEPI committee members. We will share some department updates in a slide format. And I will give the caveat as we go through the Bureau update today. It may go slightly, if we're following the slides, it may go slightly out of order than what you see on the agenda. But we will go ahead and get started here in the interest of time. So some quick rulemaking updates. You all know we've been very busy updating rules here at the department since per state law, we do a review every 5 years. And next up in the 5-year review and that cycle for rulemaking, we have EMR and critical care scope of practice, EMCT certification and training, and also an additional rulemaking on inter-facility transport requirements. So we continue rulemaking here at the department. I have to highlight this quote before we move on. As a leader, your principal job is to create an operating environment where others can do great things, by Richard Tierling. And we really believe this at the department, that as we do update our rules here, it's so important to engage our stakeholders and to ensure that we are setting the administrative code to be able to enable our providers out there in the field to be able to do great things. So thank you to all that participate in that rulemaking process, and we look forward to sharing updates with you. The next slide that we will send out as part of this slide deck are the links to our ongoing rulemakings. If you would like to follow along, we have the links there to scope of practice, EMR training, and paramedic enforcement rules, as well as the inter-facility transport requirements and ambulance and healthcare institution requirements that are currently being discussed. A quick note before we move on is that scope of practice has been reviewed and approved by the Medical Direction Commission as of the last meeting, and that one is the furthest along in the rules package. The rest of them are slated to continue for public comment, and that they would go into effect by January 1, 2025. We'll go ahead and keep rolling through our slide deck. We've been asked to share some updates on what is new in Article 9, since we have recently implemented the new ground ambulance rules. In the interest of time today, I will not go over all of this slide since it's quite a few bullet points, but we do want to draw the stakeholders' attention to some of the resources available here. We do have a couple checklists that were developed for our certificate of necessity providers, and we want to make sure we're sharing and promoting those checklists to the community moving forward. If you go on to the next slide, I think that's a little bit about what is included in the new annual reporting checklist. In terms of what is now required of our CON holders in rule, there is annual reporting now outlined to include not just the ambulance revenue and cost report, but also a CON compliance report and a House Bill 2609 response time summary report. Again, as we share these slides out, we want to make sure that all of our CON holders have access to those resources, including checklists. And in our next slide, these are some additional resources. These are all hyperlinked resources that we want to make sure are shared out widely. Going on, we have some state and federal updates. And as we go through these slides, I will try to call on the SMEs that we have here with us today. Julia, can we go to you next to talk about the strategic plan updates in the next couple slides?
Yep. So the Bureau is continuing to work on the strategic planning process. So we're working on drafting our final needs assessment report and plan. And throughout the month of August, we're planning to provide several opportunities for stakeholders to provide feedback. So we will be visiting each regional EMS council to present the draft plan and collect feedback. And then also we'll hope to have, we'll have a Google form that people can provide feedback anonymously as they would like. A more final draft of the need assessment report and strategic plan will be shared at the September 21st STAB and EMS Council meetings for review and approval. If anybody has questions about the process or how you can provide feedback, please feel free to reach out.
Thank you, Julia. I think that Julia has a flyer that's also linked here if you guys want to take a peek. I know it's very small, but there are dates, like she said, for each region where we will be coming to visit you all. So we look forward to those discussions. I think next up is a quick share update. Julia, I'm not sure if that one was on the agenda. Anything to add there?
Nothing to add there. I think we'll have some discussion later on in today's meeting about the share program.
Perfect. So we'll keep going. Naloxone leave behind. Do we have Dave Hansen on the line, or do you want to take that one as well?
No, sure. I can take that one. So we continue to have naloxone leave behind kits available. We have plenty of naloxone, so please feel free to share any of this information. Dave's available to provide technical assistance or provide information about the training. Just a couple of numbers. We do have over 2,600 personnel trained across the state of Arizona, which is pretty awesome. Over 2,000 kits shipped, 35 agencies are participating, and about 250 kits have been scanned in so far. So we know for sure that those have been left at the scene. So We'll continue to provide updates on that as we go further.
Just a plug to our Naloxone Saves Lives campaign that we'll send out. Next up, we have our math guru with us today, Mike Hamilton. Mike, can you share an update with us on GIS?
Yeah, actually, we've done a couple things in the GIS department recently. We've been supporting Julia on the needs assessment and strategic plan. But what I wanted to give you guys a quick demo of today is we have a new CON viewer. It's a public-facing app that allows anybody who wants to go onto the website, see and gather information about the different CONs that are available. I'm going to start sharing my screen here real quick. And hopefully I can get the right tab here. Okay, so let's see if we can get this now. So the first question is, where is it? This is the EMS and trauma systems page, and then you go down to the ground ambulance programs and the certificate of necessities folder. And then right underneath the red thing here is a CON service areas viewer. That will take you right to the link that I'm about to show you. Okay, so the first thing that you're going to do is you're going to get kind of a window or a box here giving you some basic map instructions and application instructions. Look at them, take a peek, and then you have to do is just click anywhere else on the screen, and that goes away. So this is the CON ground ambulance viewer and data repository. You can either scroll around, scroll in, or you can come over to the search box, which is on the left here side, and it might be a little cut off here. And you can either type in the CON number, or you can type in what the name of it is. It's going to give you suggestions, and then it's going to zoom in. So that's Fry Fire District. You can click on it, and it's going to give you all of the specific CON information, holders, contacts, and all those fun things. And it's being slow right now. Or you can zoom in and click, and it'll give you the same information. This one's kind of unique because we have a lot of CON overlap. This one is picking out Priority Yavapai, Williamson Valley Fire District, and one more that's in there. So I would just suggest go in there and play around, click and select. You can also search by the name or the number, and should be an easy, quick site for the public to gather information about the CONs. I think I stopped.
Thank you very much to Mike Hamilton for sharing some of those GIS updates with us. We continue to recognize how powerful it is to be able to use the GIS information and to look at data from that geographic map level. We look forward to working with Mike to be able to look at our data with that other layer moving forward. And as you can see, there are many, many apps that have been developed that we look forward to sharing with you. All of these are public facing, and you will have the link in your packet that you received today if you'd like to click around in our needs assessment or look at some of the other things that have been developed by Mike and the team. If we keep rolling, we have some slides that we will cover later at our education committee meeting. Thank you to Dr. Dan Mojo, who I believe is on the line or will be during the next meeting to share some of these updates. Let's keep rolling. Finally, we just wanted to cover our EMS and trauma dashboard updates and let you know that a refresh is coming soon around September each year. We do republish our data for the last year, and we will be sharing our State Trauma Advisory Board report that is due by October 1st. So more to come. I do have to plug our Falls dashboard that our committee has been working on and providing feedback on, and anything else that Dr. Bradley would like to cover.
No, I think a big thank you to feedback we received from this committee as well as staff regarding fall injuries, ground level falls, hip fractures. and then to Voxel and Carissa and Ann, who really were able to take all those requests from the two committees and put together those dashboards. We did have a stakeholder meeting in June, and I know many of you participated in that, and really good discussion about how to address what is the #1 cause of traumatic injury in the state of Arizona, which is fall injuries, and looking to see how we can potentially affect change with that patient population. So good discussion in regards to kind of charges associated with that, patient outcomes, how we collect that data, and some options moving forward. So again, this committee, especially as kind of the data experts for the state, we really value the feedback you can provide us. This helps us guide what we put into these dashboards and these reports, and will allow us to keep improving those. So a big thank you to everyone who has participated.
Thank you, Dr. Bravo. There is one last slide in the slide deck. I'm going to do a quick check to see if Carissa is on the line from the Bureau.
Good morning. Yes, I'm on the line. I can go ahead and give these updates. So we wanted to provide you guys an update on the ASTR transition. So the Bureau is still in the process of going through the RFP. And so that closed on May 1st. So we'll give you an update when that is finished. We did want to let you know that we got an update from our vendor ESO that our current Trauma One system, due to security risks, they are sunsetting that system out at the end of this year. That changes our timeline from June of next year to January 1st. So ADHS is gathering info from you guys to make sure we can have a smooth transition to our new system. We'll be sending out a survey to get feedback from you guys on that.
Carissa, thank you so much for that update. I know we're also going to get an update today from our trauma registry user group. And so we can certainly talk a little bit more about this one, but like Carissa said, there is a survey that's gone out to all trauma centers, and we can certainly circulate that more widely if this committee or others are interested in participating. But we appreciate the team leaning in and working so closely with all of our trauma centers on that upcoming transition that will be effective January 1. Beyond that, I want to circle back to introduce some of our new Bureau staff before we move through the agenda. We do have quite a few new hires this time of year that we like to introduce to each of our committees. So I will say they are not brand new. They've been with us now for several months, but they are new to this committee. So please let me introduce Dr. Dan Mojo, who is our new training program manager. We also have Nanette Jaju, our CON quality analyst. Mike Garachi, who's sitting here in the room waving. He is our new CON administrator. And at the front desk, if you guys get the opportunity to say hi to him today, is Daniel Mesquita. If you call the Bureau or if you stop by, he is the friendly face. You will see waving to you and greeting you. We are so fortunate to have these new team members join us. We continue to also hire. If you know anybody who is interested, we are still hiring in our CON program for leadership positions over ambulance services and the CON and rates program. And thank you very much for allowing us to share some department updates today. I'll hand it back to you.
Thank you so much.
I think one more on there is just item F. So if we can click on that linked.
Yes, thank you, Dr. Bradley.
So just a reminder to this group who did vote on this change that then went to EMS Council. So EMS Council did approve the recommended timeline for making the cardiac arrest data elements as part of SHARE, a part of the Premier EMS Agency program. So this is a really big step for our cardiac arrest data in the state of Arizona. Since we initially designed the PEEP program, this is kind of the first change to the requirements to be a Premier EMS agency. So we are really excited that EMS Council supported the work of this committee. This is the timeline that we have put together. Thank you, Julia, for all your work making this look nice. And we did send this out by Gov Delivery to everyone. We want to make sure that this is widely available to all EMS agencies. So many of you are going to see this messaging in multiple different formats and places. But just to remind EMS agencies that these data elements specific to out-of-hospital cardiac arrest, we are now going to be running validation scores on that to hopefully improve our EMS quality data in regards to out-of-hospital cardiac arrest. So we are in the timeline right now where TEPI approved that. Initially, that went to EMS Council. EMS Council has subsequently approved that. We are going to be doing wide messaging over the next 6 months to make sure that everyone is aware of this. You work with your vendor. This should not be an issue for any of the vendors in the country, really. These elements align with CARES and NEMSIS 3.5, which is the national EMS data set, when they made the 3.5 conversion, they made sure that they aligned with the CARES data elements. So we don't think this will be a barrier to any EMS agency as long as you're utilizing NEMSIS 3.5 data variables, which to be an AC peers you are required to be. So the key thing is going to be just making sure this is all live within your bill that you have with your vendor, and then really communicating to your EMS personnel the importance of why we gather this. This data, historically, when SHARE was developed, was pulled manually by the SHARE team, and that was 15 plus years ago. With today's technology and really everyone being on EPCR platforms, we want to make sure that we go to a more up-to-date, streamlined version and improve our data quality. This out-of-hospital cardiac arrest data from Arizona's EMS agencies is what made Arizona a leader in cardiac arrest resuscitation and why this is so important. So January 1st will be when we start collecting that data. We will have the 3-month time frame that we will then run the report to kind of collect that data validation, and then we will follow up with the EMS agencies if they did not meet that score. So just want to remind everyone and say a big thank you to this committee for all your work you did to support the SHARE program.
Thank you.
Any questions on that?
Great. Hearing none, we're going to move on. Let's move to the updates. First up, Trauma Registry User Group. Maria?
Hi, everyone. So yesterday we had our truck meeting, and of course, one of our longest discussion was the Trauma One transition. So Carissa made us aware they're starting August 15th. They will no longer be taking email tickets. So she will be sending a form out, and she would also be helping if they don't respond. She said that she's there, like you can CC her on the form that she'll be sending out. We also discussed COVID is no longer a requirement for the state or NTDB to be coded, but the facilities can still capture that if they would like. And we went through, we have new EMS triage criteria. So she's been working with all the sites, because now we have a longer list to pick. So she's doing some educations to other registrars. But I think that's it. Our mainly discussion was Trauma One transition, because a lot of facilities are, a little scared because ACS visits were one. But I guess there's more information to come on that.
Thank you for the update. Next, on to Trauma Program Manager Workshop. Heather, I don't know that I saw you.
She isn't on. Someone else.
Hi, yes, I'm on. Sorry. Can you hear me?
Perfect.
Can you guys
Yes,
hear
we
me?
can.
Yes.
Okay. Yeah, so unfortunately, I wasn't able to attend. I was out of the office for this meeting, but it looks like they had a pretty good agenda from this meeting, going over some injury prevention initiatives, some transfer discussion, some of our data visualizations, and then went over our trauma awards and announcement. So that was so we held that for our trauma program managers meeting at Valleywise Health. And our next one, I apologize, I was just looking to see, our next trauma program managers meeting looks to be, oh, hang on, I missed it. It'll be in a couple of months. I can't find the date. I apologize. So we will have the next trauma program manager meeting scheduled soon. That's all we have.
Thank you very much for the update. Next up, EMS Registry User Groups. Ray?
Yes, good morning, everybody. EMS Registry met on 6/27/24. Answer of the meeting, I believe Adriana Smith gave the quick national PED assessment just to have everybody see if I believe the deadline is the 31st of this month. So if your department's very complete, thank you. Otherwise, if we can get as many as possible, it'd be great. Karen Barnes covered the C1 as the C1 administrator, covered HB 2609 team, and also the reporting tabs and checklists and instructions on the ADHS website. Then also covered heat-related emergency activation, the importance on how the CDC, NIOSH, Highway, everybody uses that data for the NEMSIS criteria and why it's important. For those that don't know, it's eSituation.20 or .12 on there on provider oppression. That, like with all the heat emergency, especially here in the state, really important to have crews make sure that that's selected. That's the impression. IFT code for NEMSIS, the big thing to take away from there was to make sure that crews, or if they're selecting IFT in your EPCR or interfacility transport, I'm sorry, to make sure that the state code for the facilities match up and select the right facility. That's to make sure that the state gets the data needed to is as accurate as possible. The other last thing was EMSIS 3.5.1 is slated for late of 2025. I know everyone's probably just got over 3.5, but looks like the update's already coming out toward the end of the year, and that's about all I have.
Thank you, Ray. Let's move on then. Discussion and action items. First one is to review and approve the draft minutes. For those of you in the room, please take a few minutes to review the draft minutes in your packet. For those of you online, feel free to look at those as we scroll through real quick. I'm happy to entertain a motion to approve or amend as you feel fit.
Make a motion to approve.
Thank you, Ray. We have a motion to approve. Is there a second?
Candace Williams seconds.
Thank you, Candace. We'll open it up for discussion. Any discussion on the draft minutes from our meeting in March 25th? All right. I will call for a vote then. All those in favor of approving the minutes as submitted without any changes, please say aye.
Aye.
Aye. Sorry, my fault. I forgot we are changing things up today. Please use the chat to put your vote in if you are online. If you're in the room, we will do a verbal vote. Let's try again. My apologies. Those online, please type into the chat yes if you approve. Those in the room, please say aye. Key to the room, please say aye if you approve. Oh, you're not a member. Oh, I see. Sorry, I'm confused by the people at the table who are in there. Okay. Wow, that was rough. Any opposed? Please say nay.
New process may have failed.
Yeah. Any who wish to abstain, please say aye. Yeah, clearly. All right, we're gonna go back to the verbal vote if that's okay with you. All right. Tried, failed. The draft meeting minutes are approved as submitted. Thank you all very much, despite my fumble. Let's move on then to discussion on the Certificate of Necessity annual response time reporting. There is a hyperlink on the agenda to this. I'm not sure who's going to lead this discussion item.
Shelley, would you be able to take us back to the Bureau's slides on the checklist? There is a hyperlink, and we'll definitely go back to that one. But just to draw everyone's attention, we did share a slide here, and we wanted to make sure we were covering what is included in that annual reporting checklist. This is among the new requirements that are now in place through the new CON rules. In our EMS portal, there is a way to be able to submit reporting to the department. That is the department format for submitting reporting. And the new annual reporting includes 3 components. It is, again, that ambulance revenue and cost report, the CON compliance report, and the House Bill 2609 summary report. The checklist, we'll show it here in just a minute. It does go through how to submit each of those components in the portal. And if you go back just one slide, Shelley, we wanted to make sure that we were letting this group know that we did request that all of our CON holders submit that information by July 1. So we did begin collecting that information from all of our Certificate of Necessity holders as of July 1. The providers that either did not submit reporting or submitted incomplete or non-compliant reporting are going to be receiving a letter from the Bureau with instructions on next steps. And we wanted to make sure that this group also knew that CON holders must submit annual reporting within 180 days of the certificate holder's fiscal year end. And so for some of our providers who operate on a calendar year, that means that their annual reporting and response times are due to the department as of June. And for the rest of our providers that operate on a fiscal year that is July 1 to June 30, their annual reporting and response times are due to the department at the end of the year, so December. We began receiving all of this data as of July 1, and we are just now reviewing and getting back to the stakeholders with next steps. So wanted to share this with TEPI since you guys especially have an interest in data. The department is receiving quite a bit of new data through this annual reporting, and we will be sharing some of that information on our website because by statute, the House Bill 2609 response time summary reports must be made publicly available. So once we receive all of that annual reporting by the end of the year, we will start making that reporting available publicly on our website. Shelley, if you can take us to that checklist, just to take a peek at it really quickly. It is a one-pager. It does go through those steps of how to gain access to the system, how to pull those reports and submit them to the department. All the hyperlinks should be active for people to click on and be able to log in. And if you have any questions at all, we of course have contact information at the bottom of this document as well. Big thank you to Ann Bosbrink, who is our image trend easy peers guru that you guys all know and love from the data community. We also have from our certificate of necessity program here with us today, our other two contacts listed on the form, Karen Barnes and Mike Bracci. Thank you guys for being the points of contact for this checklist. And we look forward to reviewing all the data coming into the department and sharing that with TEPI as we move through this quality assurance process.
Thank you. Anything else on CON stuff?
I am just scanning the team to see if they have anything to add. We just want to make sure that we are being good resources and partners to everyone as we go through this new reporting process.
Thank you very much. Any committee members or public questions on the CON reporting process and to come reports on CON members? All right, thank you all. Appreciate it. Let's move on then to item number C. This is discuss, amend, and approve the shared cardiac arrest receiving / referral center criteria. Please do everyone take a peek at the attachment. For those in the room, it's this one. For those online, it's attachment 6C1. Adam, do you want to walk through this? Is that fine?
Sure, yeah. We'd like to revisit the shared cardiac receiving referral center requirements. This is following some inquiry from our member hospitals asking about updating these requirements, specifically a couple the targeted temperature management bullet points on the receiving facility, as well as the EEG bullet point on the receiving facility. Those are the main inquiries that we're getting about. Maybe there's been some updated information and they'd like more clarification as to whether or not we're going to precisely require that. And so I'd appreciate the committee's input.
And another one for the receiving center was the availability, any gaps in coverage for the percutaneous or PCI capabilities. So I think that was a question we've gotten from several stakeholders in some of the regions as well, is do facilities maintain their status as a cardiac receiving center if they routinely lose their ability to kind of receive those patients? And what is the kind of time frame? So I think that was another one that we also wanted to get input from this group.
Thank you both. Anything else before we open up for discussion?
Also the data submission dates.
Oh, in order to sort of model after the other data collecting entities that we have, we decided to just fall in line with that. So we decided that, or we're proposing that the data submission follow those guidelines, which are explicitly typed out as a bullet point that gives you the dates for submission.
Thank you. Thank you. All right, we'll open this up for discussion. Allison, I see your comment in the chat there. Thank you. Allison says excellent work. I'm excited to see this, the refresh of this program. Other comments? Oh, yes, thank you. Allison, should I take that as an emotion to approve?
We do need to discuss first. Are we looking for a motion to discuss?
We're gonna discuss.
Yeah, we need to discuss.
First, second, we're gonna discuss. Yeah. So what we're looking for is a motion to approve this, and then we'll open it up for discussion. Now you got first and then second. All right, I'm going to ask one more time, just to make it clear for committee members online. We are looking for a motion to approve this and a second so that we can start discussion. Candace, thank you for your motion to approve. Do I have a second? Thank you, Allison and Tiffany. Double exact same time. Well done. Let's open this up for discussion then. Questions, comments, suggestions for changes? Oh, go ahead.
Just to what you're asking about, like targeted temperature management, are we giving a big purpose of avoiding the hypothermia ideas?
The questions from the hospitals are, do we have to still be doing this as a rigid requirement? Or if we don't, does it mean we're out of the program? And so I wanted the committee's input on, is that something we should still include? Is the information involved about it?
So I think to clarify though, we transitioned away from hypothermia like 3+ years ago and went to targeted temperature management, but we are getting feedback from some facilities that they did not think that targeted temperature management was indicated any longer. So yes, specifically the hypothermia has kind of been gone for a while, but now they're questioning the targeted temperature management component. That answers your question.
Thank you. Dr. Guttinger, does that get your question?
Right, I just wanted to bring it to the attention, because it sounds like that was a big concern, and we're just going over it, and I agree that it seems like, I think from what I'm reading through here, the thing that would be worth more discussion.
Yeah, I mean, I'll put on my hat as a nerdy research cardiac arrest guy. Certainly the literature is mixed when it comes to therapeutic hypothermia and improving outcomes for cardiac arrest. It is very clear that hyperthermia temperatures are very common after cardiac arrest and are associated with bad outcomes. Targeted temperature management, which is the new term, means targeting a normal temperature or a specific temperature, whether that's a cold one or normal one, definitely improves outcomes. So from, again, a nerdy science perspective, I'd certainly support this. Open to other comments. Garth, I see your hand raised. Go ahead.
Yes, thanks, Josh. Is there a reference to any administrative actions that might be contemplated if a cardiac cath lab is down for more than 72 hours in a 30-day period? I don't see it here, and if there's none, is there any planned?
Thanks, Dr. Gamer.
Yes, so maybe can we finish the targeted temperature management and then go to that one? Because I want to make sure we kind of decide if the group is comfortable keeping that. And then that is a very important point you picked up, Dr. Gamer, to go to next.
Perfect. So as a point of order, we'll continue the discussion on targeted temperature management. Any other comments, questions?
Is there any wording changes needed? This document that's being displayed?
That's what we're going through one by one.
I don't think so yet, but we'll let you know. I see some nodding in the room, kind of in favor of targeted temperature management. Online, any further discussion? Okay. All right. Thank you, Dr. Gamer, for the brief pause. Let's then turn our attention to, I believe it is bullet. I think it's the third or fourth. Yeah. Bullet number 2, primary 24-hour percutaneous intervention capability, and then notify the share team of disruptions in service for more than 72 hours during a 30-day period. Adam, you want to, or Gail, you want to do the thought process here?
So we have gotten this question from several facilities as well as a couple of the regions of how do we manage a cardiac receiving center that is going on kind of STEMI diversion for quite a bit of time, understanding that there's times where you may have equipment repairs, someone is sick and that's your on-call team for the weekend. And so we went back and forth with kind of what is a reasonable time frame. This is a purely voluntary program. So to answer specifically your question, Dr. Gamer, is there administrative action to be taken? The only administrative action that would be taken would potentially be taking away the cardiac receiving center status. I know when this did come up previously with one facility, they went to the region specifically, explained to the region why they were in the situation they were and their action plan to address that. And the region at that time, I think, elected to allow the facility to continue to receive patients. What we felt in reviewing this with some input from a couple other entities was, what is a reasonable time frame? So understanding that a lot of times, especially for a weekend coverage, it's the same team that's on call for a weekend. So if you have someone that has family emergency or gets sick, you may lose your coverage for one weekend. So we felt like a 1 weekend or 72-hour period might be a reasonable time frame to say you can still maintain your status. But as a facility, and this is where we really want to get the feedback from this group, if you have a hospital that is saying, 2 or 3 or 4 times a month they're closing, does that facility really meet the measure of 24/7 capabilities? Because I think that's what this really comes down to be a cardiac receiving center, that you have the capabilities 24/7, understanding we want some flexibility and we want to encourage participation in the program. So that is, I think, the thing we really would like to get input from this group about how to kind of manage that moving forward. Do we come up with this and say, after X number of days within a 30-day period, that we essentially tell a facility, you would need to relinquish your cardiac receiving center and potentially go back to being a cardiac referral center?
Thank you for the background. Other discussion, Dr. Damer, does that kind of answer your question? Do you have follow-ups to that?
No, that's exactly the points that I wanted to make. I think everybody is okay with one-offs in this dynamic. It's when the action is repetitive and just speaking for my agencies, when this happens, then it triggers improper 911 calls, or not improper 911 calls. It just activates the 911 system and results in some safety net issues and coverage issues. So I think there should be some ability for an entity to lodge a complaint with the Bureau, and where it goes is a matter of what the Bureau thinks is too repetitive or too egregious. And I think the time interval, 72 hours in a 30-day period, is fine. I don't advise a change in that. So thank you for addressing this.
This would be a new addition to the requirements to be a cardiac receiving center. So currently there is nothing outlined in the program requirements specifying that. So this is a proposed new addition to essentially kind of reiterate that the 24/7 coverage has been in there since, I think, the initial start of the SHARE program many, many years ago. What we're looking to do is to add essentially bullet 3, which is to say, if you have this gap in coverage, to please notify the Bureau, and then the Bureau would kind of have that conversation with the facility of where, is this a one-off thing, or is this something that we need to talk to you about potentially downgrading to being a referral center?
To perhaps build on that, I did just notice as I look at this, most of the bullets on the front page have an associated requirement checklist on the back. There isn't, it's not clear, at least from this to me, and correct me if I'm wrong, how is a hospital supposed to show that they have the ability to provide this service? Should that be somewhere in this requirement list? Or similarly, a report of times in the last quarter when unable to provide cath lab services? I think Garth's point is very valid, and correct me if I'm wrong, Garth, but we really need something to, it's a great resource. We need something to prove that you can do it, though.
So the way we have managed this in the past, when the Bureau was notified that there were some facilities that did not have that coverage, we asked the facilities to provide us their call schedules to demonstrate that they had both the physician call as well as the on-call team. So the nurse and the radiology technician. This is a voluntary program, so one of the things that it's a little bit of a balancing act in that we don't want to create a lot of work for facilities that are just meeting this on a regular basis, that now they have to start submitting additional documentation, but also recognizing that if we make it clear that you need to notify us if you have a gap, would be kind of a big first step because it's not been in place. And then we would work with them to say, okay, we really now need to have you demonstrate that you are going to maintain this coverage moving forward, which is kind of what we've done unofficially previously. That makes more sense.
So, would this allow any regional stakeholder or EMS agency to somehow report to the Bureau if there were facilities that were not providing adequate coverage, or does this?
That actually is what has occurred in the last 3 to 4 years. Right. Is we would hear from either a region or another stakeholder, hey, facility X has been on STEMI diversion for this amount of time, and then we've reached out to that facility to kind of inquire what's going on. So it's common as kind of a question. And really what we want to make sure is if we give a facility this status and this recognition, and we're allowing EMS to potentially bypass another hospital to come to your facility, that you do in fact have the capability you are attesting to. So it's that fine line when you have a voluntary recognition program, but we have worked with facilities, and some of them have relinquished their status once we reached out to them. But we're hoping that by putting it on their list, that they recognize they should be notifying us as opposed to coming from another stakeholder. So the hope is that they would notify us themselves versus kind of getting quote, quote, reported per se. A little nicer terminology if you self-report versus someone else reporting you.
Right. I think I would be very supportive of this. I think that it provides some clarity on the expectation and what the time frame is. I think putting this in here would be very helpful to many other regions who have issues with a particular facility or facilities.
And we recognize that in parts of the state, there might be one hospital that has this capability and that's it. So there's going to be a little bit different scenarios for a facility in a rural part of Arizona versus someone where there's multiple other hospitals that could be receiving this patient and providing this level of care. So that's why we don't want to just say we're relinquishing your recognition immediately, but understanding we need to look at what are the other capabilities around you within your region.
Thank you. Garth, I see your comments on there. Just to clarify that your comments, you say, I'm good with that, and then approve. Are you saying you like this bullet number 2 and 3?
Exactly, and I'm good with that. Was with the previous discussion.
Great, thank you.
And just one last thing on the record, I very much appreciate the slippery slope that the Bureau is on with respect to this. This is clearly a benefit program for the state, and it's outside of the realm of regulation. It's boils down to kind of like a substantive policy statement, and I do appreciate that at some point in time the Bureau is able to perhaps coerce somebody to downgrade their status if the conduct is repetitive and egregious. So appreciate all. Great discussion.
Thank you, Garth. Let's next move. I think there was some discussion on EEG monitoring. If there's nothing further on the cath lab availability. Anything else cath lab availability, and then we'll start with EEGs. All right, hearing none, seeing none. Let's talk a little bit about EEG monitoring. This is the 4th from the bottom bullet. EEG monitoring, continuous or intermittent, of post-cardiac arrest patients who undergo targeted temperature management is strongly encouraged. Discussion on this from the group.
This came in as a similar request, similar inquiry from facilities asking, is this something that we must do? Is this, given the overhead and given the, what it takes to execute this? So we just want to investigate that somewhere.
Previously, this had been a requirement, correct? In previous versions of this?
Yes, this was an absolute requirement initially. When we updated it, we kind of went to strongly encourage. The question that we're having from some facilities, should we do this at all? It has been kind of the request from some hospitals as they go through this process.
Let me maybe go over some medical background on this one, just for those that don't do a lot of post-cardiac arrest care on a normal basis. When we talk about targeted temperature management, there's widely 2 strategies to do this. The first strategy is what we would commonly think of therapeutic hypothermia. Patients are paralyzed. They have targeted temperatures using some type of device. Those are the patients in which you would need, obviously, continuous EEG monitoring because they're paralyzed for 72 hours and you don't know if they're having a seizure. Another method to do targeted temperature management is to observe for fever or elevated temperatures and aggressively manage that. That would be the patient population I'm assuming some of these hospitals are considering not doing this in. I think the intermittent or strongly encouraging addresses that patient population too. About that background, I'll again turn it over to the group for more discussion comments.
And I don't think the request has been specific to what they're doing for their targeted temperature management. It has been more of a blanket, not doing that. So I think that was a little bit of the concern, that making sure we don't have a situation where a patient is being paralyzed and not being monitored for potential seizure activity. So I think that the request that has come in has not been, we're monitoring for fever, and if they develop a fever, then we're implementing targeted temperature management and doing this. It's really just been a blanket, we weren't going to do this.
I think the recommendation for continuous EEG monitoring is still in most of the national and international guidelines. I think it's appropriate still to say that we encourage something that's still recommended by guideline. But I know when we had talked to some of our group, in our large tertiary care center, definitely not common that everyone gets put on continuous EEG monitoring. So I think the wording as is allows for differences in protocol and practice, but that it recognizing that it's still a recommended therapy. I think it's fine.
Online, any comments, questions? Okay, before we go to the next protocol, because I do want to make it clear there are two protocols here. The last thing to touch on is the timeline for submitting data. This requests quarterly data with a due date that is, I believe, I got to do the quick math here. Q4 is the easiest. Yes, 3 months after the quarter is. Any questions, concerns about that?
And this does align with the ASTR data submission. So that was kind of the reason we chose those timeframes, is that this aligns specifically, and especially with some of the smaller, more rural facilities, the same individuals that importing the cardiac arrest data is the same person doing their trauma data. And so this kind of gives them the exact same timeframe and deadlines with that. So hoping to align with that.
Perfect. Questions, comments on that? Seems very reasonable. Some nodding of heads. All right. We'll flip over the page, physical page, for those online, virtual page, to see the requirement and document checklist. I do want to very briefly draw your attention to the bottom one. I think we've touched on everything except the very bottom one in the bullets, submitting your data. For those in the room, I just wanted to highlight this data submission form. I don't know if you guys want to walk us through this, or if you just want us to review it on our own. This is
that is for reference about what information you collect and all the updated orders.
So for those of you online that can't see, there's a data submission form for CEDAR data. Please take a moment to look at that if you haven't already, and let us know now if there's any comments, thoughts on the CEDAR submission form. Just so everyone's on the same page, right? We have 2 data sources for share. We have a pre-hospital data source and we have a hospital data source. Obviously, we all know what our pre-hospital one is. CEDAR is our hospital-based data source. Okay. Hearing no discussion, let's move our attention to the next one, which is requirements for being recognized as a cardiac referral center, receiving versus referral. So please note the difference there. Adam, you want to briefly walk us through these requirements and highlight some differences?
Absolutely. We copied the verbiage from the receiving centers in terms of data, data submission, and out of service times. But the requirements for referral centers are far less than those of receiving centers, so these are a little more simple. This is just asking that you're able to identify all incoming patients that meet this criteria according to some AHA guidelines, and a system for identifying and reporting those patients, and a system to transfer those patients out to receiving facilities.
Okay, thank you for that review. Those of you reviewing this document, any discussion, comments? This seems fairly straightforward, but please voice any concerns. I think the idea here is to really encourage referral centers to share their data with us so we can improve outcomes across the state. All right. Flip to the back page is very similar to the front. These are the submission items here. And then the last bit of this package is, of course, the application for obtaining your cardiac receiving or referral center status. All right. I don't want to shorten the discussion, but at the same time, I see a lot of nodding heads and approval comments in the chat. So unless there's anything else, I'll call for a vote.
The other item, I was circling back to TTM, the other item I'd like the input on committee is regarding the data elements surrounding TTM. So on the cardiac arrest record itself, as you're entering information, this is the other attachment, Shelley, 6CV. So what you're looking at is our form for data entry that is regarding cardiac arrest patients coming into the hospital. The portion of it that I'd like to revisit is the targeted temperature management portion. This represents about 30% of the information, and like Dr. Bradley said earlier, reducing the barriers to keeping this as simple as possible. If we were to align with the CARES protocol asks, did you do TTM? And if you didn't, then why? And those are the two data fields they capture. So I wanted the committee's input about aligning with that CARES protocol regarding our form, and you see how many fields, how complex, how detailed this can be. I wanted some input regarding this form.
So the question is whether or not to reduce the number of elements that are currently collected now.
Yeah, so for those of you online, I think we haven't quite gotten there. Yeah, so page below.
Yeah,
there.
starting there. Very top.
Yeah.
From
So
here down is-
there are a lot of fields here, and Adam, I totally appreciate you bringing this up because some of this is very hard to fill out if you have a euthermic targeted temperature. Right? You're never going to hit a minimum temperature. You're never going to rewarm a patient. You're not going to have time to rewarm. You're going to have a lot of incomplete data fields.
And I think these were the initial data elements from 15 plus years ago when there was
When we were doing
therapeutic
aggressive.
hypothermia, and there was at that point even some pre-hospital hypothermia. So I think many of these are really outdated at this point.
So Adam, I think the proposal I hear from you is to change out everything at the bottom of page 2 through the end, to eliminate all of those data fields and replace it with, was targeted temperature management implemented, yes or no?
And
that's
if not, why not?
Those top three that you have there, just the top.
Initiate, yes,
Yeah.
no, where, if not, why, and completed.
Yeah.
To that point, how many facilities, are we still seeing a lot of facilities using the therapeutic hypothermia? First time, so not that much.
We do.
Okay,
Research,
that's what
yeah,
I'm wondering.
Yeah, I see a lot of shaking heads in the room supporting that change. Online, any comments, questions, or concerns about that? Thank you for letting us circle back around. So to summarize this discussion briefly before we take a vote, we've heard wide support for the criteria as is on the cardiac receiving center and cardiac referral center criteria to be recognized, including the entire packet front and back. We've had support for the CEDAR data fields with a small friendly amendment of changing the number of fields collected for targeted temperature management to eliminate everything below the first line. That includes select all, intravascular catheter, targeted temperatures, etc. With that friendly amendment, any other discussions before we proceed to a vote? All right, all those in favor, please say aye. All those in favor of approving this protocol as presented, please say aye.
Aye.
We got a hybrid this time. You guys are good listeners. Thank you very much. I am a horrible chair of this meeting. It's probably because my son is here. Pressure, performance anxiety. Any who are opposed, please say nay.
The Allison has something to say.
Oh, Allison, I'm sorry. Please.
No, I'll wait. I'll wait until he's done. Sorry.
All right, please say nay. And any who wish to abstain, please say aye. All right, thank you all very much. We'll consider this motion approved. Allison, before we move to the next one, something to add?
I do. I just wanted to congratulate DHS, the university, and then also all the participants for collaborating on this project that became a program, because this year it's officially 20 years old. So.
Thank you. Yes, kudos to all the DHS staff who have pushed this program forward. This is an exciting and important program. Next, let's move to the next agenda item. Discuss county level data sharing request. I don't know who's going to give us the overview of this one.
I will jump in here. And for the next two agenda items, we really wanted to take the opportunity to highlight some of the data that is available on our website in a dashboard format, and also facilitate some conversation around what the state is doing to partner and share county level data, as well as the hot topic heat surveillance. We have some new heat dashboards. So the first agenda item here is discuss county level data sharing requests. Just to orient everyone as we go through this discussion, we do have on our website our data visualization page, and it's not the easiest to find. So as part of this this discussion, we wanted to make sure folks know you go to the department homepage, you then navigate to the EMS and trauma homepage. There is a shortcut we could give you to get to our page. That's easydhs.gov/BEMS. From there, you then have to know to go to, is it data and quality assurance, Shelley? That's correct. And under there, once you click on that, you will find data visualization. So it is not the easiest to find, and we want to make it easier for all of our stakeholders to be able to find moving forward. But here we are, data visualization. This is a dashboard that we have been working collaboratively with TEPI, the State Trauma Advisory Board, and so many additional partners to be able to bring this together. You see across the top of the page here, I think that is 7 different icons that will show you 7 different data sets that do deep dives into community level data. We're very proud of this information, and would like to take this opportunity to talk a little bit about what we've been able to do at the county level and how we might be able to partner with some of our county health departments to make even more data available at that county level. The first thing that you'll see here is our, I believe that's our 911 dashboard. This is our 911 call volume that comes to us from AZ Peers. It is refreshed weekly based on the information and patient care records that come into our database. It is refreshed weekly. You can see our call volume last week based on those patient care reports was close to 1,800 calls. Then there were, 18,000 calls. Then there were broken down by type of call, 160 cardiac arrests, 70 STEMIs, 294 strokes, 1,300 falls, and unfortunately 430 motor vehicle crashes that were responded to, and each of these records represents a patient. So we're really proud to be able to highlight this to you all. Dr. Bradley, as we go through some of this data, do you have anything to add to that?
Yeah, so one of the things when we presented this earlier this week to some other stakeholders, we kind of said we need to make this much more forward friendly and easier to find for people, and also recognizing that data visualization for data people is a very common term. For most EMS providers, it is not. And so we may just have like data dashboards as the kind of front facing terminology for this. But the question when they saw this, they said, well, is this all calls that they're dispatched on? And we said, no, these are patient care records. So especially when you look at something like falls, these are falls that there is a patient care record on. So we recognize that EMS may be going on many more falls and kind of historical lift assist that aren't actually patient care records. So depending on an agency's policies, similarly, if they go in a motor vehicle crash and there's no patient or patient's defined evaluation, those would not be a record. So we wanted to also kind of highlight, while these numbers are pretty staggering, this is actually a smaller representation of the actual call volume that EMS responds to, because this is based on an actual patient care record that ends up in AZ Peers. So just to kind of highlight that, so at least kind of higher level administrators within the EMS agencies, it was kind of helpful for them to understand that difference.
If you do click on, there's a small button that says click to see weekly average. This dashboard does give you a breakdown of 911 call volume over the years. I got to tell you, my eyes are not good enough to see those numbers there, but you can see over the years the increase in reporting to the state that also follows the increase in population that we see at the state. So that information does get broken down quite a bit. And the cool thing about these dashboards is they're so interactive. If you want to see something and deep dive into it, oftentimes you're just a click away from that. If we go back up to the top, Shelley, we do not have time today to go through every single facet of this dashboard, but I'd like to take us to trauma, if you could, Shelley. I believe it's one over to the left of that one. This is, oops, you were right, Shelley, I apologize. This is our trauma dashboard by year. Each year, by statute, we publish a new state trauma advisory board report, and it is compiled in September and it is published by October. We are always about a year behind in terms of the data that is displayed here when it comes to our trauma data. You know, we started this conversation by sharing the EMS data with you. That's refreshed weekly. That data is shared with us in nearly real time and can be refreshed weekly on our dashboard. When it comes to trauma data, we are roughly a year behind when it comes to publishing and sharing that information. As we've gone through this process of refreshing the data, some of the tabs that you'll see here, Shelley, if you can just kind of slowly click through each of the tabs, they do allow communities to drill down to the county level. Some of them have maps that are available if you want to just keep clicking through, Shelley. And we can show some examples of how we've been able to display some of the information at the county level. In particular, there's a county-specific trauma rates per 100,000 residents there. You can see some of the counties do stick out in a color in this heat map because there is a higher incidence of trauma injuries by county. We want to make sure that we are providing meaningful data at the county level and that the information we're sharing is valuable to our providers and the county health departments moving forward. So this is just one example of how we've started to provide that data at a county level.
And if I can add, I think one thing just to recognize that I know Voxel is really careful when you do get to the county level data, especially when you look at some things like with pediatrics and you look at penetrating trauma and you get just young age groups, that N number is so small that it could potentially be at a county level isolated to an individual patient. So if we get to numbers that are too small, it is grayed out and not presented at the county level. So there's occasionally when you drill down too specifically, you may see that kind of grayed out. That's the easiest example that we usually kind of give to explain why you may not see your data. It comes up more commonly with pediatrics. Fortunately, there's not a lot of those incidents, but we want to make sure that the data is very highly protected. And so that is why sometimes you may see kind of a graying out and not that data present.
And we call this data suppression because we want to, again, make sure that we're not violating the privacy of any of those patients that could become identifiable in some of those smaller communities. Shelley, if you go back to, I think it was just one tab before, demographics. Again, these are just examples of some of that county level data. We have, I believe, at least one, maybe a couple of our county health department partners that are listening in today. We won't put them on the spot unless they'd like to raise their hand and come off mute. But we have been in discussions about how can we, as we get ready to republish our dashboards and especially our trauma report for the year, how can we make sure that, again, the measures that we are showing on this website are the most meaningful for our local health departments and our local providers. What we've learned through this process of putting things into this visual format is that much like people that are sitting, to my right and left today, you guys are using this stuff for applying for grants. If we can provide information to our partners where you can come onto this website and you can drill down to the level you need to be able to apply for a grant and get funding for injury prevention, that's how we want to see this data used. We want to see it bring more funding and resources into the state and to impact policy, moving the needle in the right direction. So we really wanted to open up this conversation based on some requests we've received from our county health departments and make sure, are we displaying enough metrics at the county level? If we are not, if there are specific metrics that you or the county health departments would like to see in this next round of dashboard updates. We'd like to start working on that and getting your feedback to incorporate over the next year. So let me just pause there and ask Dr. Bradley, I think you and others may have received some specific data requests. Was there anything specific that rose to the surface that you wanted to bring up with TEPI today?
I do see Carissa had added, I just kind of asked some questions just because she was on the meeting with one of the counties. And I know one of the counties was interested in discussing kind of regular or reoccurring county level data requests. And then also talk about any other data, as you mentioned, that people may want to see on these dashboards. So I think, one of the things that we look at is how that data sometimes is interpreted. EMS data is very unique. We understand that, especially Voxel and Ann, kind of understand how we get data and duplication of certain data out that number of charts for calls. And so sometimes our team can interpret that data with that knowledge that an outside entity that's not part of EMS. So.
Thank you. One comment, and then I'll turn it over for other comments. Incredibly valuable data. Thank you for sharing this, highlighting it. We do use this, at least at the University of Arizona, on a regular basis for grants, as you mentioned, which is incredibly valuable. We would not obtain that without this work. My comment / question, as Dr. Bradley highlighted, this is incredibly complex data. And I don't know, Shelley, if we can go back to the first dashboard you showed with just the cardiac arrest numbers. I was glancing at that as an example. And to me as a researcher, there's no way that we have doubled the number of cardiac arrests in this state over the last 4 years. There has to be something else involved in that. And we know, because we work with this data, that it's simply we've added more agencies who are submitting data to your system. It's just that top right-hand button there that if you click on, it does the year over year. We know that because we use this data a lot. It's striking to me that a person who doesn't use this EMS data all the time might look at this and say, what in the world are we doing in Arizona? We have almost doubled the number of people who have cardiac arrest over the last 5-year period, where that's probably not true. So I guess that would be my concern with sending raw data or not having someone like Voxel to use or interpret this data. And maybe that's something on a case-by-case basis we want to consider putting on this dashboard, something to highlight the number of agencies submitting data may also change over this reporting series time. It's not just a static number. So that was my one comment. Purely a comment. I'll open it up to everybody else for comments, questions.
I see
Thank you.
Mark Person.
Mark?
Yeah, morning, everybody. This is Mark Person with the Pima County Health Department. Just real quick about me. Part of my responsibilities for the health department is conducting injury and fatality surveillance. So we look at everything from heat to falls to motor vehicle, firearms, drugs, and poisonings. My interest in this data was I was actually able to find and navigate to the page. So thanks for putting this out there. It's really useful. I definitely appreciate the comment about the limitations with the data, and it varies by the number of agencies reporting. I work with a lot of data sets like that. We look at hospital data on a regular basis, and we do have historical years where, 2 or 3 facilities weren't reporting, and then all of a sudden they are, and it looks like the numbers go up. So definitely appreciate all that. Our interest in reaching out was mostly just to see if we could get, maybe not real-time data, but within maybe the first year, like for hospital data from the state, we get 6-month data dumps, for lack of a better term. And so we're getting that on a every 6 months. We kind of look back and analyze these things, and it helps. It's always nice to have real time, but you also want the accuracy. So our interest was looking, hey, can we get the 2023 data, specific to Pima County on a reporting system like that, or maybe it's monthly. I don't know what the best setup is. As far as the indicators on here, they're great. I mean, everything that you'd want to see is there. I don't think we had any additions, but I did want to really quickly say For sure, we love to see this data for our application for different grants, things like that. We're constantly using data from the state in a variety of different grant applications. I think the health department is almost on a monthly basis. We're almost always applying for a different grant, so super helpful. But from my perspective, why I'm looking at this data is for interventions. So a lot of the work we do with drug overdoses and firearm injuries and deaths, we rely mostly on the medical examiner and death certificate data in hospitals, but we're really lacking in the EMS. And I think what we want to do is use some of this data to fill in some of the holes that we're missing so that we get that comprehensive picture. So for example, like when we're looking at drug overdoses, we know how many people go to the hospital. We know how many people die. We don't necessarily have a great idea on a real-time basis as to how many EMS calls there are and how many of those are resulting in transports to the hospital, how many patients decline transport, and then being able to kind of match that with folks that may have a poor outcome. There's a variety of strategies that we're trying to come up with this year to combat some of these trends in Pima County. And so I just wanted to add to, yes, the grant applications are excellent, but even more meaningful for us is to come up with strategies to reduce injuries and deaths in Pima County. But I really applaud the access to this data, and I don't want to take anything away from it. I think it's phenomenal. Just would love to partner with folks on this call in the state to see what we can do to promote access for Pima County specifically, and I'm sure other jurisdictions have similar comments. But that was all I had today. I really appreciate the time and the ability to talk. Thanks a lot.
Thank you, Mark. I'm wondering, Shelley, if we could peek at the opiate dashboard. I know you have one. I just can't remember what it looks like right now.
Yeah, I'm gonna need some hand holding for that one too.
If you go to actually just type in the search bar ADHS opioid, and it should come up easily with that.
While you're pulling that up, I do have one comment, Mark. And forgive me, we may have met. I don't think we've ever met. I'm from Tucson. I'm the medical director for Tucson Fire. So very, very, I use this data literally every day. Let me throw out a potential problem and reason that I just want to make sure everyone's aware. This is incredibly difficult data to manage, and it's incredibly nuanced. I'll give you a specific example about Tucson Fire Department to highlight this. There's two ways to identify opiate overdoses, right? Paramedic impression. The paramedic thought it was an opiate overdose, or did the paramedic give Narcan? We frequently give Narcan to cardiac arrest patients. If you look for the number of Narcan administrations without looking at other parts of the patient care report, you will see ginormous spikes in Narcan administration. And similarly, ironically, things that I do as the medical director, where we say as a group, we're going to teach our medics not to give Narcan for cardiac arrest, are now going to dramatically shift your Narcan administration rates down. So things that we do in our system can dramatically alter what you all are using as indicators of, in this example, opiate overdoses. So just wanted to throw that out as a potential little wrench and to highlight how this data is difficult, really difficult. Shelley, you want to show us what you have here?
I was guided to the opioid dashboard. Looks like they got non-fatal drugs and non-fatal overdose deaths, emergency and inpatient visits, EMS law enforcement, naloxone administration, overdoses by local area, and opioid prescriptions. So you tell me what you want to see.
And to Josh's point, I think a good example of this, about 1.5 years ago, we got a request from one of the counties who they had been contacted by their local news media because their local news media had looked at the ADHS dashboard and were concerned about the rates of naloxone administration in their county because, again, that misinterpretation of what the data meant in the pre-hospital setting. And so this was something where once the local county health department reached out to us, we met with them and explained why the EMS data is the way it is. And then they were able to give that as a response to the news media request. But it is a good example of how sometimes there is that challenges of when you have an outside entity looking at data and not understanding the context of that data.
You also have data completeness issues that could affect the appearance of the data as well in certain fields that may or may not be captured as accurately. You have issues with that as well.
Yes, I mean, your data is only as good as the data that comes in. So a good example would be some agencies, depending what they utilize with primary impression is a really good example. Some agencies are very good with utilizing accurate primary impressions, others are not. And so while that is a big proportion of their validation score, and one of the reasons why we like to focus on that, we do know that if we are pulling data from primary impression, which is kind of the NEMSA standard, so it's the national standard, that is often not accurate, because you will see like no complaint and it's a patient who had significant medical issues and you got under the chief complaint, and that's where the EMS provider kind of documented that. So that's kind of part of the ongoing education with our EMS personnel too.
And I apologize, Shelley, I can't pull up the dashboard on my own computer. I'm getting the wheel of death. And my eyes similarly are too bad to see any of this on the webinar. So I would encourage folks to take a look at this, I think, and if anyone has questions or comments on the opiate dashboard, it is another great resource. We similarly use this. And I see another question here.
You have 9 minutes.
Oh, thank you.
We're doing good.
Yeah, I'll make it through. Don't worry. One more question. It says, did you discuss if layers for these dashboards will be available for download or by request? I'm not sure I understand that question. I don't know if you want to come off mute to explain a little bit more detail, or maybe someone in the room knows what this means. I'm not a database guru.
I can answer that. Ariel Moreno from Office of Injury and Violence Prevention. So that's our opioid dashboard. It's not in a downloadable format, but if you do need it, you can absolutely request from our data team any additional information. Also, too, just letting everybody know it's got a 6-month gap like everybody else's data, so it's not real time. But thank you for all the comments that were made.
And from the Bureau's perspective, I'll just say we want to continue these discussions because it's so important to hear how our local partners use the data and what their needs are. So we want to continue these discussions. We are reviewing some of the data requests that we've received. From the Bureau perspective, I'm sure we heard from Ariel that they've received data requests as well. And we will be working closely with our county partners moving forward to ensure we're meeting the needs. So
thank you.
Thank you, guys.
All right, that was a discussion only item. So I'll take the liberty of the chair and moving forward for the interest of time. Last agenda item, discuss NEMSIS and ADHS heat-related surveillance dashboards.
And I know we're short on time, but Shelley, if you can just flash up the heat dashboard. We have some of our heat gurus on the line today. I think Jenny Botsford's joining us. Jenny, I hate to put you on the spot with only a couple minutes left, but there are both national level heat dashboards that use EMS data, as well as now an ADHS dashboard that is linked here that is looking at heat maps across the state. We want to make sure that those resources are available to our TEPI committee and any community members that are also closely monitoring heat here in Arizona or at the national level. So those are available. If you all have questions, one of our go-to people is Jenny Botsford, who is on the line, along with our Chief Heat Officer, Dr. Eugene LeVar. Dr. Gaither or Dr. Bradley, anything to add to that discussion item?
No, thank you for sharing this. Anything else from the group? It's a great resource. I love it.
Yes, and thank you very much to our EMS community who we have not displayed EMS calls on the public facing dashboard when it comes to heat, but in the background, you all know that the EMS data does capture quite a bit in terms of the heat burden out there with the patients that we treat. So we appreciate you all, and I'm sure we will continue to have discussions about heat surveillance and how we could use EMS data in the future.
Thank you. All right, moving on. If you have an agenda item to be considered at the next meeting, please submit those to Shelley. Her email is on the agenda there. We'll next move to call for the public. All right. Hearing nothing and no chats from the call of the public, let's turn our attention to upcoming events. There is a wide range of events you can see here going into the fall. I will leave it up to you all to read about those. I will not bore you with my voice. Please note also there is a DHS news and conference page that you can click on and a training programs update page. With that, the next meeting, November 21st, same time, same place, same virtual opportunities to enjoy. And I will adjourn this meeting. Thank you all.
Thank you.